Hey PAs, welcome to PA Gold Standard. Are you entering your behavioral medicine rotation of PA school and wondering what to expect? Well, today on this video, you will get all your answers, all your questions answered. We have the lovely Anam Jafar here.
Hi.
She just got off of her behavior medicine rotation. I believe it went fabulous.
It did.
For her. She really enjoyed her time, so she is definitely going to be the foremost for this subject. Hi, thank you for being here.
Thank you for having me on your channel, Michael.
Yeah. So what type of settings do they have for PAs in behavioral medicine?
So typically our program offers a couple of different settings. One of those is a long-term care facility, so things like assisted living facilities or skilled nursing facilities. And then there's an acute care setting, which is hospital-based, so you're dealing more with inpatient psych or with patients that have to deal with a psych ward. So those are kind of the two options we were presented with.
Gotcha. What was your particular rotation?
So my particular rotation was the long-term care facility, which I initially wasn't too excited about, but I ended up having a very good rotation.
So what exactly is a long-term facility? What type of settings were you going to?
So we kind of traveled between different nursing homes. So I dealt more with the elder population. I was dealing with a lot of Alzheimer's, a lot of dementia, which I wasn't too familiar with, and I don't think we spent too much time on in school. So it was nice to see it because it is very common. And I also dealt with some younger patients that were dealing with, let's say, alcohol withdrawal or drug abuse or things like that. So it's a good variety, but mostly the elder population.
Gotcha. So it definitely sounds like, and from what you've told me, you had a really good time. What was your daily experience like?
So initially we would just go in, we would get a list of patients, so that could be new patient consults or patients that we were following up with medications. We would kind of just get a list, we'd get some info on the patients, what medications they're on, what their dosages were, and then we would just go around and kind of talk to them. The other thing I want to say is half the battle in a nursing home is trying to track down your patients because they could be outside, they could be drinking coffee, they could be in the music room, so that's kind of half the battle there. But it was good. So we kind of just go around, find these patients, and then you take them back to their rooms and you talk to them.
So there's a lot of yelling for people. Hey, Miss Dolores, are you? Hey.
That is exactly what my days consisted of, actually.
Okay. What is the role of PA in behavioral medicine?
So this is something that I kind of learned in my rotation because I wasn't too aware that PAs had a role in behavioral medicine. So it's different from psychology or a psychiatry. So what it is a lot of pharmacologic medication management, titrating medications, checking their side effects, checking their labs, making sure that they're handling those medications adequately, and just kind of monitoring those side effects. And for me personally, in the long-term care facility, age is a big factor in these patients and comorbidities. So just knowing what medications work and just following up with them and kind of titrating those medications. So a lot of pharmacology, I would say.
Okay.
Yeah.
So you mentioned that y'all are managing a lot of pharmacology with them. What are some of the main classes that you prescribed from, like typicals, atypicals? What are some of the classes that you would definitely say no stone cold before you go into your rotation?
So I would say that the kind of gold standard with psych is learning SSRIs. That will cover most of your depression, which you will see a lot of depression, whether that's major depressive or a depressive episode or things like that. SSRIs are kind of your mainstay there. Starting a patient on them, you have to realize that it takes almost 4 to 6 weeks for those medications to titrate. So you're not looking for an immediate effect. In your atypical antipsychotics, which I wasn't too familiar with, but it is used a lot of psychosis and those types of behaviors, you will definitely be using a lot of atypical antipsychotics.
So now we're going to play a little game here. And Anam doesn't know about this one yet.
I don't know about this.
I just actually came up with it on the spot. So if you have been studying for your behavior medicine rotation and you think you know some things, you might be correct and ready to go on it if you can answer these questions faster than Anam. All right?
Okay.
All right. Okay, so what setting were you in?
A long-term care facility.
All right, so this setting will be in a long-term care facility. All right. So you hear a loud voice coming from a room. You run up and the patient is in an acute psychosis. What medication will you initially treat him with?
I am Haldol. Is what I would go with.
That's pretty fast.
That's pretty fast.
That's pretty fast.
Ding.
Okay. All right. Question number 2. You have a questionably bipolar patient who is now having a bout of depression. What will be your first choice medication? And
Ding.
there's nobody else here.
So I would go with an anticonvulsant. Because when you're dealing with a bipolar patient, it's very important to not give them an antidepressant because that can swing them into a manic episode. So very important with the risk of depression, things like that. So steering more into Tigatrol and those types of medications, which are considered the anticonvulsant class, is what you would want to stick with for a bipolar patient.
Yes!
Yes.
You might have some studying to do, but all right. Okay, moving forward. What was one of the craziest or a couple of the craziest things that you got to see as a student on your rotation?
Whew. So, there's something that we studied a lot about in books, and when you're studying for your behavioral medicine rotation, you'll come across this term called PBA. I heard a lot about it in the facilities. I heard about it with my preceptor, and I had no idea what it was. I looked it up. It's something called pseudobulbar effect. And usually these patients have been managed on medications for such a long time that they basically develop an emotional incontinence. So they're unable to differ laughter from crying and going through big bouts of these spells. And I saw a classic case in a woman in a facility, and she was just so upset, but her smile was kind of plastered on from ear to ear. And she was, you know, she had the tardive dyskinesia with it. She had lip smacking, all of these things that you kind of read about and you don't really get to see. But that was something really cool that I saw. And obviously a lot of delirium tremens, a lot of alcohol withdrawal, and, you know, patients that are absolutely losing their minds in these facilities. That was pretty intense.
Gotcha. That sounds intense.
Yeah, and if you're young and you're walking around the nursing care facilities, you'll probably get hit on. So I mean, it is what it is. Gotcha. Yeah, I got a couple growls.
What is a growl?
It was pretty adorable.
Watch out for the growls.
Yeah, watch out for the growls.
Right.
No, but these patients are harmless. They're adorable, and I really enjoyed it.
Right.
I saw a patient that was 109, and that was really special too.
Wow.
Very old, man, very sweet.
What was his? What was the secret to life? What did he say? What was the key?
I don't know, but I did ask him how his day was going, and he told me he just got back from a trip from London. So he was very demented, but very adorable guy.
What is a piece of advice you would give a student who is really passionate about going into psych and either setting up their rotation or going about having a good experience with their rotation?
So I think the first kind of big important thing with psych is don't get upset based upon which facility or which setting you end up in. because initially going into it, I wasn't too thrilled about going into a long-term care facility. I didn't think I would see anything cool. I thought it would get very repetitive very fast, but it's all about what you draw from your rotation. So you can go in with that mindset and get bored. You can do that for anything. But I think if you really kind of take the time, establish the rapport, sit down with these patients who have incredible stories, and if you catch them on a good day and just being able to kind of see that development, or seeing a patient that might be depressed and going through something, starting them on a medication and then being able to see them get through something like that. It's very, very rewarding. It was really special. So whereas, in inpatient and acute setting, you might not be able to follow that patient through. So there's pros and cons to both, and I think it's important to kind of open your eyes and be accepting of the situation that the setting that you get.
So a lot of you might still be in your didactic phase right now, and to speak on that point, she just said it being very rewarding. So the gratifying feeling that you start to get when you're out on rotations and you effectively treat somebody's depression or schiz or something like that, the gratifying, the feeling that you get whenever you successfully treat that is kind of why we're all here.
Right.
So it feels like right now you are just like killing it in the books and you have no life, but afterwards, this is something that you're going to be passionate about, and it's worthwhile because you're actually affecting people. So she just spoke on that, and it really does come back. So that's definitely something to look forward to. All right. So lastly, if you could go back in time and give yourself a bit of advice before starting psych or behavioral medicine,
right,
what's a bit of advice you would give yourself to do well?
Just reading up more on the pharmacology, I would say. I think everybody feels like they have a general understanding of psych medications, but even with something like SSRIs, you have to realize that there are so many. And if one doesn't work, knowing which one to go to, which one will fit your patient population. There's just a lot of factors that go into it. So that would be it. But I learned a lot from my rotation, which was really nice.
Very good. Can you see yourself going into psych after school?
I'm not opposed.
Okay.
It was a really good experience.
All right. Well, she's looking for a job. There's any psychs out here wanting a very competent new PA on the team. You have one. All right. Well, that's all we have. Thank you, Anam.
Thank you, Michael.
You've been great.
Thank you.
All right. You are really a force for the women in medicine.
Yes.
I think you can see it down here. And PAs alike. So thank you for coming. All right, guys. Well, I hope you enjoyed this episode of PA Gold Standard. I want to remind you to subscribe if you like the episode, and if you have any questions or any ideas for topics that you would like to see covered anymore, leave a comment below right now, and I'll get back to you. Thank you for watching the episode. Talk to you soon.